Dr. Shammas is the president of the Midwest Research Cardiovascular Foundation and is also the director of a long-standing cardiovascular and peripheral vascular meeting in Davenport, Iowa, which is called the Midwest Cardiovascular Session. He's a prolific writer and has contributed over 200 articles in coronary and peripheral interventions. And it's a great pleasure to have him take us through whether stents or non-stent strategies can deliver reproducible success. Thank you very much, and welcome, Nick.
Subhash, thank you very much. Okay, these are my disclosures, and I can add to this one more thing. I am a non-stent person, so I'm already biased. And this is pretty much what my point of view is going to be, but I'm going to hopefully give you enough data and enough information. Maybe I can convince you. We'll see. Okay, so let's start defining what we're talking about. When we talk about a stent strategy, what are we really looking at? We're looking at primary stenting. You're going into the procedure, and the frame of your mind is very simple. I want to put a stent in. So primary stenting is your thought process, and you can do this with a bare metal stent. You could do this with a DES non-polymer-based stent. This is the Silver PTX stent. Or you could do this with two different modalities that we do not have at this point, and they are currently in development, a DES polymer-based stent, as well as a DES bioabsorbable scaffold stent. And the non-stent strategy, and I like to call this actually provisional stent strategy. Why is that? Because you don't really go in and try to put a stent or do a balloon without thinking that, okay, if it fails, what am I going to do? You're going to do provisional stenting. So really any type of a non-stent strategy is a provisional stent strategy. You can do it after plain old balloon angioplasty. You can do it after a drug-coated balloon. You can do it after atherectomy plus adjunctive POBA. Or you could do it after atherectomy plus adjunctive drug-coated balloon. And in fact, that is underlined there in the slide because that's currently my way of doing things. I tend to use atherectomy, and a lot of patients follow this by a drug-coated balloon. You can also do it after a scoring balloon and an adjunctive drug-coated balloon. Or you could do it after a chocolate balloon and an adjunctive drug-coated balloon. Again, there are some stuff coming up on the horizon very soon. They are currently in development. These are the drug-coated scoring balloons and the drug-coated chocolate balloon, which may very well end up being very well disruptive technologies because they may make things very easy for us by reducing potentially the stenting, but at the same time allow us the delivery of certain drugs to reduce target lesion revascularization and improve patency. So what people in the U.S. are currently doing? Well, as you can see, stent still leads the way. And stent, that's in 2012 from a U.S. peripheral device market data. Plain old balloon angioplasty still is commonly applied in about 20% of patients. But then we see some atherectomy appearing, and we see atherectomy and stenting. And in fact, atherectomy, with or without stenting is about 1 in 4 procedures we do currently. This is very well shown in the XLPAD registry. This is data from Dr. Banerjee's group. And as you can see, about 67% of the procedure in the XLPAD were stent-based, and the remaining one were non-stent. About half of them, were atherectomy-based treatment. So what's the problem with stenting? Well, stenting is easy to do, actually. There's not a whole lot of problem from a technical standpoint. That's what operators prefer because it is an easy procedure. It's a short procedure. It's a quick procedure. There tend to be less radiation, to the patient and to the operator. So there is a lot of advantages. But what's the problem, short and long term? So if you look at this slide and you look at 12, 24, and 36-month primary patency data, and as you can see, if you have a short lesion, which is less than 10 centimeter, and if you look at the first year in follow-up, your patency rate is very high. It can be up all the way up into the 90% range, if not more. But if you start looking at the lesion length as it gets longer, as the lesion length gets longer and longer, you start losing patency, and you lose it very rapidly. And in fact, after 15 centimeter lesions or so, you can start looking at a patency rate in the first year at about 70%, but then at 3 years, you could be looking at a patency rate that can be as low as 30 to 40%. Well, if we look at that and we start looking at restenosis, which is essentially what we're talking about here is loss of patency, And you look at the randomized trial, and we have, 6 trials listed here, actually 5 trials. 4 of them are with bare metal stent, and the middle one, it is a drug-eluting stent with the Silver PTX. But if you look at patency, if you look at the short lesions, the 42 and 45 millimeter, and in 2 randomized trials right now, there's not a whole lot of difference in patency rate when it comes to the primary stenting versus plain old balloon angioplasty plus provisional stenting. If you look at the longer lesion at 71 and 132 millimeter and higher, now you start seeing some differences, and you can see that the patency rate, seems to improve, with stenting compared to plain old balloon angioplasty. In fact, restenosis is less. And in fact, if you look, at the middle bar with the Silver PTX, there's clearly a difference, between plain old balloon angioplasty and using a drug-eluting stent. So if you look at the bottom line is patency does not seem to change a whole lot with the short lesions when you go for POBA plus provisional stenting, but it does make a difference, and you have better patency, when you start looking at, the longer lesion in favor of stent, and it's almost always seem to have a favorable results when you start using drug-eluting stent. And then when you look at, however, what does it mean, restenosis and target lesion revascularization? What is the relationship between those two? For years we've been debating, every time you lose patency, guess what? You end up with another treatment. Do we really have to do this? If you look at patency, and you lose patency and your lesion is about 50 to 70%, and patient is asymptomatic, why do you want to treat those? Why do you want to subject them to another target lesion revascularization? So if you look at the relationship between the percentage of patients who have restenosis versus the percentage of patients who end up going to a target lesion treatment, and that is a summary data from 5 randomized trials, and you can see there is some relationship. It looks like a positive relationship, but it is a weak relationship. And in fact, if you look at the relationship, the R2, the coefficient, is 0.28. So it's a weak positive relationship. What does that mean? That means not every time you lose patency, you're going to end up with a TLR. And why is that? Well, 50 to 70% lesions commonly end up being treated medically because the patient is doing fine, and you do not have to end up with a repeat revascularization. So if you look then, and you look at the other side of the equation, I showed you the exact same trial, but this one, we're going to look at target lesion revascularization rather than patency. And now suddenly you start losing the advantage that you have when it comes to the gain in patency. The TLR rate, in short lesions or long lesions, with primary stenting seems to be very well, leads to the exact same TLR, down the road at 1-year follow-up. The only exception, again, is the Silver PTX or the drug-eluting stent, where you continue to have an advantage of TLR, in that regard. So, okay, we got better patency, but we're not adding too much, when it comes to reduction of target lesion revascularization. So really, what about how does that translate into the quality of life and the walking distance? Again, these are the same trials, and as you can see, when you look at quality of life and the increase in the distance score and the walking distance score, there's not a whole lot of difference between primary stenting and plain old balloon angioplasty and provisional stenting. And even when you look at the drug-eluting stent with the Silver PTX, you can see that the ABIs at 1 year were the same. You can see at the Rutherford classification distribution is the same. You can see at the walking distance, the walking speed, the climbing is all the same. And the only difference is some form of an index that was generated in that study, and it's called the Clinical Benefit Index. And that is a summary of various parameters, as you can see down: freedom from persistent or worsening claudication, rest pain, ulcer, or tissue loss. And you can see there is an advantage when it comes to the drug-eluting stent. So when you combine all those together. So we need to revisit really what's important. Is really patency the endpoint that should be guiding our clinical trials? Or should we think about TLR, TVR, and quality of life as the ultimate goal that, we need to consider? And in fact, isn't that a deja vu questions, that we've seen in the coronary intervention? Well, yes, for years, we've used restenosis as our main endpoint in coronary trials. But guess what? We changed that. Now we talk about target lesion failure, and can't we just think about a target lesion failure as our endpoint when it it comes to peripheral vascular intervention. And I would challenge you to define target lesion failure the same way as we do that in coronary literature. And we should define that as vascular death related to the intervention. We should define this as an amputation related to the intervention and TLR related to the index lesion. And if we can create a target lesion failure for PAD, we probably will start matching with the coronary literature right now, and we've learned this after 15, 20 years of coronary clinical trials. So what about other problems that we have with stenting? There are many forces exerted on the stents, and you've seen this slide numerous times, and you can see there is extension, contraction, torsion, compression, flexion. So what's going on with this? Well, you can end up with stent fractures, and as we know, the higher the stent fractures, the more likely restenosis would occur. In fact, that happened in class 3 and class 4 stent fractures. And these, you can see this very clearly, where areas of restenosis can occur in displaced stent fractures or class 4 stent fractures. Again, there are many other problems with in-stent restenosis. We have long diffuse lesions, high rate of embolization. Again, as Dr. Banerjee mentioned, they are rarely just restenotic. When they occlude, they are also thrombotic. They recur very frequently. There's no real good effective way to treat them. You end up with more layers of stents in the same patient. You end up with a higher fracture rate. Maybe that would affect, upcoming technology in terms of delivering drug to the area that has restenosis when you have multiple layers of stents, and may very well impair future surgical targets. So again, stenting has lower restenosis at 1 year than PTA, particularly when it comes to longer lesions. But longer lesions, again, have a high rate of restenosis no matter how you treat them. There is no difference in the TLR with primary stenting versus provisional stenting using bare metal stent. The primary drug-eluting stent or provisional drug-eluting stent has a lower TLR, and we need to keep that in mind, than just angioplasty or angioplasty with provisional bare metal stenting. Quality of life, walking distance, claudication are not consistently altered at 1 year by primary stenting versus provisional stenting. And femoral popliteal stenting, again, has its inherent problem relating to the nature of ISR lesions and stent fractures. So how to avoid stent-related problems? Well, I say avoid routine primary stenting. I would consider, however, stenting, and I'll take a little bit different point of view here, to consider provisional stenting as a preferred method with drug-eluting stent. I will consider drug-eluting stent in short lesions because that's where the data support their use the most, mostly in proximal and mid-SFA. And I will support drug-eluting stenting in advanced limb ischemia when you want to maximize the opportunity for blood flow to stay to the area of the wound so you maximize wound healing, particularly in patients who have wound ulceration. Otherwise, my strategy is to reduce stenting first, potentially with atherectomy, and then couple that with adjunctive drug-coated balloon. So we've seen the optimal strategy in peripheral and PAD treatment is altering vessel mechanics, reducing the chance of dissection, protecting the distal tibial circulation, and now we have the anti-restenotic, the biological modifier. And we know that we could alter, the mechanics of a vessel. We can do that with the atherectomy devices, and we have many of them. We could do this now with specialized balloon like the angiosculpt, the chocolate balloon and others. And the bottom line is we know when we do the atherectomy, we're not altering TLR very much, but we're reducing dissection rate drastically. In fact, this is the atherectomy versus angioplasty randomized trial that showed over a 50% reduction in stent rate when you use atherectomy initially, couple that with low-pressure adjunctive balloon angioplasty. Again, the price you pay, it can potentially be distal embolization, and you have to almost always have a low threshold for use of filters in those patients. If you look at the Calcium 360 trial, the exact same finding, a randomized trial that showed a significant improvement in vessel compliance, a freedom from restenosis that tended or trended better toward the TLR, though not statistically significant. But again, freedom from major adverse event in this particular study was very much in favor of orbital atherectomy and adjunctive balloon angioplasty compared to angioplasty alone. If you look again, stenting rate is reduced markedly following orbital atherectomy. Dissection rate is reduced markedly, and clinically it looks like TLR rate trended in the right direction. If you look at the Compliance 360 trial, exactly same data. This is data for orbital atherectomy in fem-pop calcified lesion. And you can see when you do the atherectomy, couple that with adjunctive low-pressure balloon angioplasty, you're going to have less bailout stenting and improvement in vessel compliance. So when we look at examples, this is an example of a very calcified, eccentric, distal SFA disease, and we're using, the TurboHawk, in that situation. You can see just by removing some of that calcium, low-pressure adjunctive balloon angioplasty can lead to excellent results, and you really do not need to stent that. And try to balloon angioplasty this directly, I'll guarantee you'll end up with a stent. If you look at, this is a case where an area you do not want to stent, the no-stent zone, and we know very well common femoral arteries, in popliteal vessel, you really want to avoid stenting as much as possible. And you can see in this case here, this is a patient with good runoff using the jet stream atherectomy, and you can see just with the jet stream alone, great results preserving, the profunda femoris artery with low-pressure adjunctive balloon angioplasty, excellent results in the common femoral artery. This is exactly when you look at IVUS, you can see this is not just a doddering effect, but this is clearly a tissue excision effect, a clearly removal of calcium in that situation and other plaque. Again, this is another nightmare type of lesion where you have irregular, long, severely calcified disease. Again, this is a case where I usually put a filter in, using a jet stream atherectomy here and low-pressure balloon intervention. You can see the results are excellent, and you preserve that single runoff to the patient, which is simply that peroneal vessel. This is another case of a CTO, and I usually, on all my CTOs, I try to get Interluminol because I really like to use atherectomy on those patients. Once you are sure you're inside the lumen, make sure you put your filter in, again, to protect from distal embolization. Jet stream atherectomy, low-pressure adjunctive, that's actually just with the jet stream atherectomy, and low-pressure adjunctive balloon angioplasty, kind of great results in that setting. So again, now we can focus more and more following, on the atherectomies and low-pressure adjunctive balloon angioplasties, eliminating the stent or reducing it markedly. Now we can start focusing on adding an adjunctive drug-coated balloon. And as you can see, all these trials very consistently showed a reduction in target lesion revascularization, with the exception, of course, of the Levant trial that showed actually an improvement in patency, but not in TLR. But every other trial that we have done has contributed, and you can see this in the bar graph. All your orange bars here, are showing their low TLR compared to just using plain old balloon angioplasty, as you can see in these blue bars. Again, infrapopliteal intervention, clearly a meta-analysis showing that drug-eluting stents work very well in that setting, in reducing target lesion revascularization. The IMPACT DEEP trial was a little bit of I don't want to say it's a disappointment, but it was a little bit of a concern. As you know, this is a 358 CLI patients, with two co-primary efficacy endpoint, late lumen loss and clinically driven TLR. Even though it didn't show statistically a significance in terms of or significant change in the TLR rate between the two arms, there was a slightly higher amputation in the drug-coated balloon arm. We do not know why, but if you look in details, you find out that the drug-coated balloon arm had significant impairment of flow to start with. They've already had multiple treatment, possibly could be a selection of a higher risk patient population. Drug-coated balloon versus drug-coated stent, probably not much of a difference. Dr. Banerjee's team, here showed in a nice review in JACC, showing us essentially an overlap, at up to 3 years follow-up when you summarize all that data. So we do not know that for a fact. We need randomized trial to compare them, but it looks, at least from the observational data and compiling existing data, that this may very well be the case. So in summary, provisional stenting with bare metal stent has the same TLR and quality of life when compared to primary stenting. Provisional stenting or primary stenting with drug-eluting stent has improved clinical outcomes compared to primary stenting with bare metal stent or provisional stenting with bare metal stent. Atherectomy reduced dissection. Drug-coated balloon are superior to POBA. Combining atherectomy with drug-coated balloon will likely end up with a reduction, not just in stent rate, but also in target lesion revascularization. But watch for disruptive technology on the horizon. These are the drug scoring balloons and the drug chocolate balloons that will be appearing here in the coming year to 2 years. So again, the optimal strategy in infrainguinal intervention will be a combination of reducing stenting, altering biology, and protecting the distal vascular bed. Thank you very much.